Welcome back, Smile Mentor family. Today is a little bit of a nerve-wracking day for me, but a fun day nonetheless. I mean, highly educational for you guys. We were blessed to have Dr. Ratana and Dr. Iskander, who performed the surgery and the conversion, the prosthodontist piece of it. Even though they're both surgical prosthodontists and could have done the entire surgery beginning to end, of which I've actually seen Dr. Iskander do, they worked as a tag team on this. And so what we wanted to do, because Dr. Ratana has a patient before too long, and today's a work day, we wanted to get his position and help understand from once the baton is handed off, if you will, to Dr. Ratana from Dr. Iskander. In this specific case, sometimes it's reverse, but in this case, we wanted to start with Dr. Ratana on that. And so, gentlemen, thank you.
Thank you.
Good morning. Dr. Iskander, even though we're starting with Dr. Ratana, share with me at what point does a baton handing off, right? You hand the torch, you have done several hours at this point, and now it's Dr. Ratana's time to come in. We're about at that point where he's going to be coming in. Help share with me what you're finishing up to then now know to call Dr. Ratana in.
When I finish the surgery, which is the extraction part, the implant placement part, the abutments, angulation, all this kind of finishing status of the surgery, suturing up, then Dr. Ratana take over and start doing the let's say the calibration and the alignment of the upper and the lower arches and the impressions and the prosthetic, aesthetic, functional part after the surgery.
Okay.
So surgery is done, and now we are ready to prepare for the second day delivery or the temporary, long-term, provisional. This is the part that he's taking over.
Okay. So right now I saw you ratcheting. Are you just tightening up abutments?
Yes.
Or okay.
This is after we place the implant, we put the abutment, which is like the middle piece between the implant and the prosthesis. This is what I'm doing here right now. And now I'm suturing, I believe. Yeah.
Okay. Are you suturing right now? Did you suture on this or did Dr. Iskander?
We do it both ways, so I don't know exactly in this case, so we need to check, but I think he's almost done with the abutment selection, abutment placement, and then sometimes he graft at this point. So maybe you may be grafting a little bit in some spots.
Sometimes I take advantage of him and I finish it like, you
Exactly.
Let him. And so now we have Dr. Ratana. How did you know it was your time? Does Dr. Iskander let you know?
Yes, it depends in every case, you know, but sometimes I'm with a patient, so he needs to do a little bit more. But in this case, for example, I was waiting for you, so he just called me and I started immediately, yeah.
Perfect. And then, so you come in, he's getting, like he said, the abutment set that he's put the implants in. So the screw, the post goes into the jawbone. He's got that set. Now the abutment is the in-between.
Yes.
It's the connector between the implant and the prosthesis or the teeth.
Yes.
So you're putting on the abutments, and we did 6 implants, right? 5 new, 1 original. Is that correct?
Used one from your existing implants, yes.
Yeah. And so you put on 6 abutments. Now, at this point, you're done with the surgery.
Yes.
And the baton is being passed over to Dr. Ratana. So Dr.
Correct.
Ratana,
And now my assistant just like placing some healing caps on top of the abutments so the gums will not collapse until he comes within a couple of minutes or so, just to get ready.
Okay. Healing caps. I've heard those. We've talked about those. Now that I've seen where they go, that's why. That's when you use them, is at that point?
Yeah, I mean, after you finish, you need to preserve the gums from closure. So you just put healing abutments just temporarily until the next step starts.
Okay. Dr. Ratana, she's putting on the healing caps right now? Or
I guess you already did.
Yes, the healing caps.
Yeah.
And I think now we're going to start with the suturing part, yeah.
So in this case, you did do the suturing. Is that correct?
Yes, sir.
You know, one of the things that people, you know, even Dr. Iskander and I talked about this. He goes, I don't know how many patients might get excited about watching a surgery But one of the reasons we're doing this is to show how complicated this is. This is not an easy deal. This is not a filling that you're going to do. You have multiple assistants. You've got an anesthesiologist in the room. You've got 2 doctors that are going about this. I mean, there's a lot going on in one of these surgeries other than one of the others. And so do you always have 2 assistants in the room with you as well, or?
Yes. Yeah, most of the cases we have 2 or 3 assistants working with us.
Okay.
Yeah.
So now you're over there gloving up and walk me through and I'm trying to ask Dr. Iskander how it went. That's
That's a normal part of the process. Every patient is trying to talk and trying to ask things on that.
Is that normal?
Yes, yes.
Okay, so in that process, one of the things I wanted to let our viewers know, if you're watching this, you got to be going, did that hurt? It looks like it hurt. I can tell you that I don't remember it hurting, which is the key. I went home sore, but the surgery itself, you felt some spots at points, but it really wasn't the pain. I'm a dental pain guy. I understand it. Blood pressure, 160 over 120 a lot of the times if I'm just sitting in the chair. But this actually was easier than I thought it would be, despite how it looks. So you start suturing up. What do you have to do to prepare so the abutments are in place? Walk me through what you're doing.
So basically at this point, I'm numbing a little bit more, because the local anesthetic, maybe you were having a little bit of sensation. So we just numb a little bit more.
Okay.
We have the healing caps in position, and we're going to start suturing the soft tissue and adapting that soft tissue to your abutments, to creating a very nice environment for your prosthesis. That means that we're going to move and adapt that soft tissue depending on each implant, the position of each implant.
Around the healing caps? So
Yes,
the
yes.
healing caps, you got the bone, which now the posts are inside the bone. You've got an abutment on top of the implant, and then you put a cap, basically, almost like our light cap or a lens cap type deal that goes over the abutment. Then you sew up around that healing
Kind
cap?
of, yes. Basically what we need to do, because we have different type of tissues in your mouth, okay? So we are looking for the very good quality tissue to be around the implant, because that is going to protect your implant in the long term, okay? So we need that good quality tissue. We call it keratinized tissue. So it's a very strong tissue around your implants. So at this point, I'm just trying to adapt the tissue in the different positions depending where you have the implants.
So you're taking existing tissue there, you're separating out a specific kind of tissue and
remember that you had teeth before, like 1 hour ago you had teeth, okay?
Yes.
So you have the tissue is in different positions. There were, Dr. Iskander did a bone reduction. The implants were placed in different positions, not exactly where you have teeth and all that. So now we need to play a little bit with the position of the tissue, because your tissue is not at the same position that before when you had teeth. So we need to reaccommodate that. Yeah.
How many doctors would you guys say that perform this surgery understand that?
Everybody should understand that. That's like a basic stuff about this, if you're doing these kind of procedures, you should be trained for that too,
Some clinicians, or even some patients, think that implant is bone and implant and crown. The soft tissue is as important as the bone around the implant to make a successful restoration. Same importance, not just bone and soft tissue. If you put the best implant on earth, on the best bone on earth, and you didn't adjust or you didn't deal with the soft tissue, the jacket of this area correctly, you are at high risk of losing the implant, everything. It's not just
because you're
bone.
letting the back bacteria in?
Yes.
Is that kind of peri-implantitis is what is, if you don't do this part right, you have a higher risk of that?
Believe it or not, sometimes you can, some implants can be placed not in a best bone position or in not best angulation, but you have a very well established soft tissue on top, the protector. This implant will be much safer than placing in a very good bone with poor soft tissue.
Okay. So how much of that do you guys look at in your planning side of things?
I mean, everything is connected, you know.
I know.
That's part of what we try to teach to other doctors since 2006 or something like that, is that everything should be connected. Implants are not a surgical procedure. Prosthesis over implants is not just a prosthetic procedure. So everything should be connected. The patient's health, the bone, the soft tissue, the prosthesis, the occlusion, that means the bite of the patient. Everything is, it's super important. This is a multifactorial thing, you know, so you cannot manage only one or two factors. You need to manage all of them, and then trying to remove the negative factors as much as possible. So that's, every case is different, every patient is different, every patient has different tissue, different bone, different bite, different function. So you need to deal with that, and you need to understand every factor as much as possible so you can manage every case in a very predictable way.
That is highly encouraging.
I have one follow-up. Let me 1 minute and see what's going on and come back.
Okay, perfect. So Dr. Ratana, I know Dr. Skander had to go see a patient, but if you will, you're finishing up sewing up, and we had talked about how important it is to make the right tissue go around those healing caps.
Yes.
Once you finish up with the suturing part of it and getting that foundation ready now for the prosthesis, right? You got healing caps that are exposed around tissue that is now brought back together. Yeah. Right? The bone is no longer exposed.
Yeah.
So now you're reviewing what the case looks like.
Yes, I'm checking. I mean, maybe I'm trying abandments, because we have different ways to do this part, because sometimes we do this 100% digital, sometimes we do it 50% digital, 50% the analog way, okay? So in most of the cases, what we do is that we already have this denture or this duplicate of the WhatsApp or the possible position that we planned based on, remember, all the pre-op part where we have all the information about your bone, your actual position of teeth and everything. So we do a WhatsApp that's like a mock-up of where we want the teeth for this type of prosthesis, and we print that. Now I need to transfer that from the digital world to your mouth, to the analog world. So I'm going to your mouth. I have different references. In this case, I have your palate, and I have other references, you know, that I'm going to attach this to the recently placed implants.
Yes.
And then I'm going to start playing, and I'm going to do a bite record with that. So I'm going to use it in the prosthodontic field. We call this like a rim, bite rim. So I'm going to use this WhatsApp, printed WhatsApp that is, I mean, you have your teeth. It's a printed complete denture, basically, okay? Without all the flanges and without all the tissue touching on top of the ridge, because we only have contact with the palate in this case. So we adapt and we partially convert that complete denture, printed complete denture, to the position of your new implants. And then I'm going to be able to do a bite record. And it's going to be a very stable position, because this is a screw-retained device that is not going to move. And I'm going to be able to check other aesthetic factors, for example, the position of your anterior teeth, the midline, the occlusal plane. So I'm going to start playing a little bit with that. Based on that, I'm going to start connecting the virtual planning with the analog world, that's you, okay? And I'm able to check, we are on track or not, we need to do changes, we need to change position of some teeth or not. So this is a very important part of the process, because we can recheck what we have done in the digital world with your face. That we already had that information, remember, with the face scan, with the CBCT and all that. But I'm rechecking. I'm able to touch that part again and see it in your mouth and say, okay, yes, we did great. The midline is good. The occlusal plane is good, or not. We need to change these 2 millimeters, 3 millimeters here. We need to angulate this. And then based on that bite record, I'm going to be able to transfer that information to the designer, and he's going to be able to do minor changes, no changes, big changes. It depends on every case. But at this point, because we do this on a daily basis, the technician is very well connected with us in communication. So we don't do a lot of changes, because we are already very close, But it's very important to check it.
Yeah. So you end up, I know they called you for your patient, and patient, if this is you watching it, I'm sorry I'm keeping them an extra 2 minutes, but if you guys take you planned denture, the one that's pre-printed, it goes in, if I'm hearing you right, you now go, okay, which I saw you adjust a little bit because, again, there might be audibles in the surgery part of it, right? Something, an implant might have to be adjusted. Is that a fair?
Basically, what we do is that we need to open like these windows on that printed denture to be able to bond it to the newly placed abutments, because we have the multi-unit abutments, the one that Dr. Iskander plays, and then on top of that, we have these titanium cylinders that are screw-retained to those abutments, and those are the ones connected to the prosthesis. So in this case, I need to open like these windows to be able to sit it and connect it to those abutments, so then I can take it out and mount it and do whatever I want. Yeah.
So once you've done that and you now got it to where it's going to sit, do you then take it back to the lab and then that's what they printed the next 24 hours set off of?
With that information, they will be able to have a newly recorded bite. So I'm going to have a bite in that moment. I'm going to be able to verify, as I said, all the information that we planned digitally.
Yes.
So yes, I said, yes, everything is good. The bite is this, proceed. So they will able to digitize again that analog portion of the process. Once they digitize that analog portion of the process, we start from a next level, because we already have,
more data.
Yes, we already verify all the digital files, we already make them match with your face, we already make them match with your bite. Now we start next level. Let's go and continue with the designing of the new prosthesis that is going to be a completely newly designed, of course, based on all the wax up and information we just gave to the technician.
Okay. And then once you give that to the technician, you put the denture in my mouth. It's then, you guys had it there for 24 hours? Isn't that what we did?
I mean, basically, imagine this, I don't know, this is at noon or something like that.
Yeah.
So we delivered the immediate load prosthesis that is a newly one piece. In this case, it was milled, but sometimes we mill or print. Yeah. We have different options. But we design and create a one-piece prosthesis for the next day, okay?
Yeah, because it's drastically different. I mean, going from this one that you put in here to that next one was just
because as I said, this one is not your prosthesis. This one is just a device that I'm going to use to collect the data and to connect things and to make a bite record. As a prosthodontist, it's not just like, let's guess. No. This is, like it should be.
Yeah.
Yeah.
Okay. I think you have answered every part of where you did on that. If we're still here, we'd love to invite you back when you're done with your patient. But if not, if we do finish up ahead of time,
perfect.
Thank you.
Thank you so much.
I really appreciate it.
Thank you, man.
Okay. Now, Dr. Iskander, you're back up.
Yes, sir.
That was good and concise. Okay. So now, to help out understand a little bit, Dr. Iskander, about getting ready for surgery, getting the patient ready for surgery, the anesthesia piece of this. Mm-hmm. I've gotten to see you have multiple ways you can sedate a patient to go through this. So walk me through how you make a decision on what a patient needs from a comfort level, or do you always do IV sedation now, or walk me through that, because not everybody does.
When you have such kind of procedures, this extensive one, extractions, grafting, things, implant, you really need actually the patient to stay still, calm, relaxed, stable, so you can perform your work, right? Believe it or not, the quality of the work the clinician can do is highly dependent of how the patient is cooperative and still on the chair.
Yeah.
So if I'm working with a patient and he's in pain or is uncomfortable, I will be distracting my focus of the procedure between doing the procedure and taking care of the patient's calm and no pain. Okay, but that's not right. It affects the quality on the accuracy. Like let's say that I want to do something, I might have to rush it or something so I can pass this point through. This procedure, here we have no really room of errors. Really. Yeah. It has to be done right and precise. You are dealing with entire mouth here. Yeah. If you are watching a movie, interesting movie for 2-3 hours, you might get bored. Imagine you are sitting on the chair without sedation, opening your mouth and having all this around you. No fun.
Yeah.
Patient need to be like fully sedated.
Okay.
In this particular procedure. It's lengthy, long. You need also your time to focus, your way to focus.
Yeah. So you guys bring in an actual dental anesthesiologist. It was Dr. Zia in this case, which I had met several times before.
A lot of the patient doesn't know that one of the specialties of dentistry is dental anesthesiology. Not just like orthodontist, periodontist, or no, another one actually even accredited by the ADA to be dental anesthesiologist. It's for this, for dental procedures.
There's not that many out there.
Not really.
Okay, so which gave me a high degree of comfort because you're talking about having the patient sedated, and that can go wrong if not handled rightly. You know, I mean, you want to make sure that that process of how you're putting them under, that they're well monitored and that.
When you say you, not me, right? You can be good in everything.
Right.
Right. So you need every piece of this one to be given to the specialist who can handle it well and have long experience doing it. Okay. Yes, I have do some experience in sedation, fine. But do I really need to focus on the patient monitors or the patient mouth?
Oh.
I believe I need to patient mouth, right?
Yeah.
So I have to have like anesthesiologist with me,
right?
Specialist.
Right.
All what he's doing in the room actually is taking care of the patient, looking at the monitors, communicating with me if anything I need to be aware of, and so forth. Yeah. This is what he's doing all day long, every day. Checking patient health, medical history, what he needs to do, this, that, what kind of level of sedation he can go, is general health.
Yeah.
It can tolerate or no. Sometimes, you know what? This is not an office setup. This patient is medically compromised to the extent this surgery needs to be done in a hospital. It happens.
Yeah, that's a great point.
Taking care of the patient's health is as important as, the mouth.
Yes.
Sometimes you have a very easy dental procedure, but health doesn't help you here.
Yeah.
You have to be careful on that.
You know, and you talked about it earlier of how the patient being still, your focus, your worry, because it's high intensity. I mean, you're dealing with some intense work being done that if you're distracted over here because the patient's...
Imagine I'm working with drills with a speed of 1600 RPM. I'm dealing with very small pieces of implants, 10 millimeter, 12 millimeter. You see like how very delicate, precise, small piece you are working with in a patient mouth? And no, it has to be still.
Yeah. And, okay, I know you're about ready to get started with the extraction piece, but before we do that, I want to ask one more question about the anesthesia side. I had a lot of fun in college, and some of that was recreational fun that included substances that might or might not have been legal at that time. And so how important is it for somebody to share if they had a season of partying, if you will, of using illicit substances? So how important is it for that person to share with the anesthesia?
Very important. I can't stress enough how important it is.
Yeah.
We are your doctors.
Yes.
Right? we are in this closed surgical room together.
Right.
Now we are in charge of doing this procedure for you. You need to share with us everything you had, what kind of medications or drugs or whatever thing that you had in your life, even recently or while ago. That's affect what the anesthesiologist will be using to control and to give you the right level of sedation.
Yeah.
Even for me to know what kind of pain medication I will have to give you afterwards.
Yeah.
Some patient, if you already have been in very high doses of hydrocodone or something for a long time, the amount of pain medication I'm be giving normally for patient might not work for them.
Right.
We need to know, nothing to hide.
Yeah.
I mean, you have to share all this information, even if it's very private, confident. We are covering here. There is HIPAA things. This will not be shared with anybody on the planet, but we need to know
Except
it.
in my case.
But we need to know it.
Yeah.
Because that control a lot of things. Again, this procedure is not just dental implants plates in bone. If you see steps behind the procedure, numbing you, controlling you, making sure all the monitors, your oxygen level, your heart rate, your blood pressure, all this need to be controlled. How much medication I will give you based of your body tolerance to put you on the right state of comfort.
Comfort, yeah. You know, I wanna take a minute and just really and share with you from a personal side of things. You can feel very embarrassed if you had a season that you might not be a part of now, but there might have been drugs in your history or alcohol in your history or any of those kind of things, and you can feel tempted to not share that information with them. But now I think hopefully you guys see the complexity of what goes into this. It's not just they have one shot and they put that in your rear and now you're sedated. No, it's a custom cocktail. And so to give them the information that they need to properly treat you and not put you in jeopardy. So it's in your best interest to be honest and vulnerable with the doctor. Like he said, there's HIPAA regulations. He's not going to go text it out on Facebook or anything like that. But I do know the fear of that. And I even, with Dr. Zia, I wanted to dance around the subject some, and that's probably why I woke up a little bit, from my history. So again, part of what I want to share with you guys is what I've done well and what I've learned also in the process. So I want to encourage you guys on that. Okay, I appreciate you sharing that.
One more to think, like sometimes, usually this procedure is done under level 3 or 4 IV sedation, okay?
Right.
This is what we call it. Some cases with some history of drugs or so, we need to put the patient on general anesthesia, not just IV sedation. So patient sharing with us this history is very important also for us to determine IV sedation is enough or no. Sometimes it happened a couple of times with us, or a few times, we started the IV sedation, it didn't work. Not just didn't work, the patient started to act differently,
Really?
like very aggressively.
Really?
That's why we have to quit, stop, abort the surgery, and we have to reschedule the patient for a general anesthesia setup. Different story. The reason why patient didn't share with us some very important medical or history that he has.
Okay.
So it doesn't harm you just to tell us from the beginning. This is what I have. That's what I have been through. Just be prepared. Fine.
Side note to the other clinicians out there, help make this a comfortable environment for patients to feel. I mean, I was blessed because I had a long relationship with Dr. Iskander and even Dr. Ratana and Dr. Zia. And so I was in a very unique position. But I know what it's like to be a patient and be scared of being judged and feel shame from the clinician. Some dentists out there try to use that as a tactic to sell. Please don't, in this position, let that patient know that it's a safe place to be honest, open, and that you're on their side to help make this a success. That's why I felt comfortable in doing this, but I can see why some might not be. So clinicians out there, please take note of this. Okay, So now you start the extraction process. We had talked about it in the case planning side. Sometimes you extract and then open up the gums to be able to get to the bone. Sometimes you open up the gums and then extract. What did you do in my case?
I opened the gums first.
You opened the gums first, and that's because I had one of the teeth that was half broke? Or
Not just that. Your bone was very dense. So it's much easier for me at this point now is to open the flap and relieve some of the bone before extraction to make the extraction easier.
Okay. Okay, and because I'm having this done at a younger age, in my 40s, instead of in my 60s or 70s where bone might not be as...
It's not really very age-related.
It's not.
You just have to thank your mom giving you good milk when you are young. So
okay.
It's like very well built.
I will thank my mother for that. Okay, so you opened up the gums to relieve the pressure off the bone, and then what remaining teeth I had, you pulled out.
True.
That's the simplistic way of doing it. Okay, I had a pretty gnarly abscess, a pretty nasty abscess. Remember that? And I mean, it was bad. When do you deal with that piece? After you've taken the teeth out?
Yes.
So you take the teeth out and then there's infection in that area.
You have to cure it and clean this bone thoroughly to remove any kind of possible remaining bacteria or infected bone around this area. Implants hates bacteria. Doesn't live with bacteria. So any kind of source of bacteria from bad soft tissue, infected sockets because of like previous infections, whatever, has to be thoroughly cleaned before we even start drilling for the implants. It has to be on a very clean slate.
How do you do that? I mean, I know you know what you're doing, but give me a sample. You grind down bone around it?
You grind down sometimes. You drill certain burrs, certain drills.
To just remove. That's how you remove a lot of the bacteria is just through mechanical.
Mechanically, yes. Like
mechanically.
through tools and instruments and yeah.
Okay. So you're using those loops. You're looking in there. You're able to see the cleanliness and pretty I
can't see bacteria, just to,
right. Right.
I see like clean bone, bloody, because it's very important for the bone to have blood in it. Because if it's just like clean without any kind of life in it, which is like oozing some blood, that means it's not good neither.
It needs to heal. It needs the blood to heal.
Right. Yeah. So yes, you can see it visually, of course.
Okay.
Yeah.
Okay. So you're now prepping. You extract out the teeth, and in my case, I had. How do you do it? How do you do it? Where like on that bridge? Wait, which side was that on? I think that was on this side. Where I had that bridge, that 4-unit bridge that now came detached. You have those teeth that are over prepped and kind of soft. You remove. You open up the flap, and then is it very difficult to get those kind of teeth that have been over prepped for a patient? Do you know what I mean?
I have this question all the time. Honestly, I don't know what to say. I don't really think about this anymore. I mean, I just go there, I found a tooth, either or section it and just auto drive. I mean, yeah.
You get it out.
Yes.
You just get it out, whatever it takes, you get it out.
Traumatically, it's very important, this word, which is like to make sure when you take the tooth out, the bone's still intact. Not just like moving the tooth right and left, back and forth without without preserving the bone. It's very important when we do implants. Bone is the most precious part here. We need to pull pocket stealing, like out without touching the bone. So if we have to section it to make it in pieces, fine. If it's loose, we just pull it out, whatever.
You know, it was one of the it's funny because just as a side note, when several years ago when we were talking about extractions, and because you're originally from Egypt, and even though you got your prosthodontist over here, you were practicing basically like an oral surgeon over in Egypt. And so you said that the dental school over there, that when you went to, the amount of extractions you have to do versus the amount of extractions in the States is fairly significant. So you're kind of an expert on extractions, agreed?
Yeah.
I mean, because how many extractions did you have to do before you graduated, if you had to guess?
Hundreds.
Hundreds? Mm-hmm. And all different
It's not
kinds.
something good, I would say, okay?
You don't want to put that on your resume.
It's not the point, but poor places sometimes, the only option they have for a treatment, they will not go through a root canal or any kind of complicated. So what they do, pull the tooth.
Yeah.
Right. So being in serving in such areas, sometimes poor, low. I mean, they can't really afford doing any kind of real treatment other than just pulling the teeth.
Yeah.
And that was one of the reasons that what we were doing at this point.
Okay, I'm gonna move along because I know I could stand a while on that, but we've talked about pulling teeth long enough. So now you've taken the teeth out. You're now prepping the bone to be ready for the implants. You got to make sure the bone is clean. You have to do some bone reduction, which is leveling of the bone.
Let's say it leveling.
Bone
Because
leveling.
like reduction depends on so many factors, but it has to be leveled regardless how much reduction you have.
Because you need a good firm foundation for the prosthesis, right?
Yes, and this is one type of the All-On-4 or All-On-6 or All-On-8 restoration, because sometimes we don't do reduction at all. Okay? Sometimes we just pull the teeth only because there are a lot of issues with the teeth, with whatever thing, and you just don't need to reduce bone. We just go with the implant inside these sockets only and do it like a full arch bridge on implants without having to go to this reduction. Again, it's not cookie cutter, it's case by case thing. We don't have always to do that if we don't have to.
Well, mine you had to, yes?
We have a lot of bone loss in certain areas, bone loss in, but if the bone level like all over is fine and we have healthy areas that we can deal with, we don't go that aggressive.
Okay. So in my case, you leveled some of the bone, so now you got a flat surface to catch up where there was some bone reduction. Did you had to also do some bone grafting with me as well?
Certain areas, yes.
And that is because if there's areas that are recessed where there's been bone loss, instead of just taking all the bone to that point, you're going to try to build this bone back up to kind of get it.
In this particular restoration, the All-On-4, All-On-6, like arch bridge, it has to be as much as we can leveled for the hygienic standpoint, how to pass the water pick around it. So the maintenance and cleaning of this one is different, for example, than for arch bridge.
Yeah.
So.
Okay. So now you've got the bone and the sockets and all that kind of stuff cleaned out. You have to clean out the periodontal ligament, right? You have to remove that from any of the sockets that you've already done?
Periodontal ligament is what carries the tooth inside the socket.
Yes.
So when you just remove it,
so when you remove the teeth...
you just clean the socket.
Okay. Okay.
Yeah.
So now you're switching over to the guided surgery. Walk me through what's happening there. So now you've used this little corn cob, connects to your piece. Talk to me about guided surgery. Let's step back before we get into the specifics of the XNAV. What is guided surgery?
This one, they call it, okay, guided surgery. There is the static guided surgery and dynamic guided surgery. Okay, dynamic, it means it looks like GPS kind of.
Okay.
So it's not just template, it's inside the mouth, and I'm just following the holes inside this template. This is more of dynamic. So I'm still using my hand to do it, guided by this software. So like I see the angle as I planned before the surgery, where I need exactly to be centered, angulated, going through life. I mean, using my hand, actually not using a template.
Right.
That guide the drill. Let's
Right.
say.
So basically what I've seen the guided before is they'll print something that has holes in it, preset holes that you just basically drill through those holes. That's one, that's the static. And you're saying the dynamic is you're still freehand, but you're using technology to help make sure that its accuracy aligns to how you planned the case from the beginning.
Plus, if there is anything happened during the surgery, you lost part of the bone. If you are static, you're stuck.
Oh, that's a great point.
You can't change plan. Over. So all these templates you have been prepared before, it's gone. If anything, and it happens a lot when you, I mean, it's not 100% guaranteed that what your plan will go exactly as you do it.
What?
This is luxury. Like, no.
Yeah.
Sometimes you see things that you need to change the plan. Simply, I just go, while I'm there, change few things here and still go guided and see exactly where I can go. More flexibility.
Okay. So now we got guided surgery understood. Talk to me about this technology. So like you said, it's kind of a GPS. It sees my mouth from above, right? With how does it get the markers? Like explain to me how this works.
Okay, two ways to do this one. One of them we call it the X-nav, and one of them we call it X-mark. Okay, X-nav, you see this clip that you had, right? This one you already had it before the surgery, right? We took CT scan with it before, and then during the surgery, as you just did now with your cameras, you calibrate the handpiece to this camera on top, to this clip, 3 connected. Then when you go with the drill, you can see exactly where your drill going in the X-ray.
Okay.
This calibration things.
Okay.
This one way to do it. Sometimes we don't have this luxury that patient has teeth at all.
So edentulous completely.
Edentulous.
Yeah.
So the other way around it, sometimes they have to come also before the surgery to install small, like 3 or 4 titanium markers inside the bone under very tiny local anesthesia, and to take the CT scan, which will do the same thing at the surgery.
Okay. It will act like the other would.
Same thing.
Okay.
To connect the 3 dots, the camera, the handpiece, and this device.
You and I have been, you've been my dentist for a long time, but
Lucky me, huh?
Wow. Yeah, we're going to cover that subject at some point, what a patient I was. He used to have hair before I met him. All of it's gone now because of me. But no, seriously, because I've gotten to see you grow as a specialist in this, there was a time, and you were really good at it, at just freehand. You were able to do freehand really well. Then you moved to this technology. Why? How has it helped you as a clinician?
It's mutation. Imagine yourself walking now without your smartphone. Can you?
Be tough.
Nowadays, be impossible.
Yeah.
Before this one, actually, I said, like, why I use it? I feel comfortable doing it.
Yeah.
It's just tried it once, twice. I felt like why I didn't use this long time ago. I missed a lot of comfort, of accuracy, of confidence, just like going there without even worried. Did it go right as I expected or no? This is just put the errors aside.
Nice. And I mean, it's a sizable investment. And one of the things that I always encourage our viewers, we have it in one of our handouts, of when you're doing your consultations, ask a clinic, when you're calling on the phone, ask them what kind of technologies they've invested in, because I know how much these technologies cost, and dentists are notoriously cheap, honestly, and yet you want to find somebody that will invest in technology to really, like he said, remove the errors. So now you've got a whole grip, a whole bunch of things that can go wrong with this. How do you mitigate that risk for them to do their job properly, technology is a great tool to help out with that. So, I mean, I don't know if you guys are seeing this, but I mean, that's amazing to have that kind of crosshair pinpoint for him to be able to see multiple views, angulation. That's pretty cool. Okay, so now, and I look like I'm smoking a corncob pipe.
Tastes good.
And so, how long does it take you when you're placing these kind of implants? If in my case, it took a couple hours, but was this a normal case for you? I'm trying to help the viewers kind of understand. Like,
Yours was pretty straightforward, yeah.
pretty straightforward, nothing too complicated.
No bumps, nope.
No bumps, nothing like that. Okay, so I had you placed 5, 1 remaining. One of those was a pterygoid implant. For our patients out there that don't know what zygomatic and pterygoid are and which part of the bone that is, help explain that.
Pterygoid is the very back part of the jaw, upper.
Okay.
Right, when we need to extend the prosthesis as much as we can backward with a good back support without too much cantilevering, because usually we place the implant in front of the sinus only, in as much as we can, and then we cantilever the last molar or so.
Yeah.
If we have enough bone or good bone behind the sinus, where we go to the pterygoid, actually, will be very good and nice for the stability and strength of the prosthesis, and also help the front implants to have more support.
So you're distributing the weight more.
More and be able to go more backward as I want.
Okay. So deeper in the bedrock.
Yes. Yeah, kind of.
I mean,
the zygomatic ones, this is when all options are gone. No bone, no front bone, no backbone, nothing. This way we go. Actually, we are placing the implant in the skull, on the face, not in the jaw at this point.
wow.
The zygoma is this bone here.
Okay. So right here, that goes
like,
back.
Like, yes.
So you'd have to angulate it
yes.
back in these.
But this is the last resort. Last resort when everything else just like didn't work.
So is that typically your person who's been in a denture for 30 years?
Kind of. Sometimes even with those, we can start, I prefer personally, maybe do good sinus lifts, build some bone, and deal with the jawbone versus dealing with the skull bone. Again, I'm not saying that this is, but in some cases it just has to.
Yeah. You know, one of, is that what you did? You didn't do zygomatic with mom. You were still,
pterygoids.
You just did pterygoids, right?
Yeah.
2 pterygoids?
2 pterygoids and I believe 4 on the front too.
Yeah.
So yeah.
Yeah. You know, I've told our viewing audience of just, you know, because I had to go through this with mom and live that life, and you got to hear that story and really help her. I've given you a lot of credit for that, and thank you for helping my mom with where she was to where she is now. But, you know, you're talking about zygomatic, you're talking about some of these complicated things, and I always want to remind patients out there that you know, we did multiple consultations. We've gone and seen, and mom was a challenging case.
Your family in general. No. I mean, she has been wearing denture for how many years?
20-something years.
That was one of the reasons that finding the good amount of bone was not that easy. Yeah. So it was very crucial of how to find bone. The planning was a little bit not straightforward. Now it's gonna.
Which was unique because we went to one of the more famous ones that does a lot of marketing, has multiple clinics around the nation, and sat with that doctor and he said, no problem, get you done, you'll have your finals the next day. What would have happened if she had done that? Honestly, I mean, you know the case, you saw the bone, you saw what could he have done in that period of time to even, remember how long it took for the healing?
Yeah.
So what would have happened if you had your final restoration in 72 hours?
High risk of failure. Very high risk of failure.
Okay.
I don't want to comment more.
I
on this.
understand. I understand. You can't throw anybody else under the bus, but as a patient, it just kills me that there's not more standardization out there on how to do it right. Don't cut corners. Okay. So now I'll get off my soapbox. You placed the 6 implants. Did the case go like you had thought it was going to go? Was there any surprises during it? There was,
but it got solved during the surgery.
I know it got solved. I'm here on it. I'm asking you.
Yeah.
There were some surprises. Okay.
One of the areas that I was counting on to place an implant, when I get there, actually it was so mushy and it's just, the bone.
Really?
One of the implants that where the infected implant was.
Yeah.
Infected tooth, not this side.
Where you had to clean out the...
Yeah, I didn't expect to have all this kind of bad bone.
I mean, that's a pretty aggressive abscess, right?
Yes, and actually, in a very short time.
Yeah, it was
very
fast.
short time. From the time we took the CT scan to the surgery wasn't that long. It was almost 2 weeks. That I believe. It was much bigger than what we have the CT scan. So my plan based on the CT scan, I took the last, right?
Yeah.
But when I get there, it was already get much more.
Make sure your doctor knows how to handle an audible. Seriously.
And this is one of the things that, if we want to go back to the navigation versus the static. So if this was planned static, I'm stuck. Because I'm planning to do this one, now the whole environment has changed. Okay, what I can do at this point?
Yeah.
I have to maneuver.
Yeah, and if you just had one hole that was pre-drilled for you to stick your drill in and place the implant, and then you're hosed. Because
not only that, knowing where to place it alternatively. This is part of the designs, because I have the design. We designed the. I'm not sure if Dr. Retana talked about this one. We designed it prior.
He touched on it, but please share.
We designed the position of teeth and the bite before the surgery, and we try to place after that the implant based on the final prosthesis. We design backward, right?
Okay.
So if I'm having the implant have to be placed here to serve this particular area of the prosthesis, if I want to change it, if I don't know exactly where I should go to follow the rest of the foundation, I will be in big trouble.
So how much in that audible where you had to change it a little bit did Dr. Retana, when he had the denture to convert it, did he have to drill out some extra areas?
No. That's because like we designed together and we know exactly where we need to go.
Okay.
So I know exactly where the design before I also know the design before the surgery. And I planned it accordingly as well, right? So even if I want to change something, any angulation, I need to change it within the scope of this.
Okay. Okay, so now we're catching up to, we placed the implants. How long implants? Because that pterygoid, wouldn't it like 17 or 20 millimeter? Or?
It's common sizes, can be, again, it can be 18, 20, 25, 13. It depends on how long we have bone in the back.
Okay. Do you remember on mine? And that's okay if you don't.
I believe yours was 18, I believe.
Okay. So longest one was 18 millimeters. What was the shortest one?
In your case? I can't remember.
Okay. What is the shortest one you use, just out of curiosity, for this procedure?
When I have to, I can go as short as 8 sometimes in certain areas, but I don't immediately load those. Okay. They have to heal completely first before we go. Okay. In some areas, we have to go that.
Okay.
Short implants are not bad. Mini implants are. Different story.
What's the difference? And I've seen, let's talk about it, because I know you've never done mini implants.
Mini implants depends only on the threads and just as if screw inside the bone, right? There is no osseointegration now. It's just like for stabilization of denture. This is what the mini implants are.
Okay.
The short implants still have this capability of osseointegration to fuse with the bone, to have a very strong foundation. It's just being short, I don't feel that comfortable to load it immediately without being... but once it's fused to the bone, done deal.
Okay. Okay.
Doesn't matter.
How did you know if the one that I had existing, so you used an existing implant I already had, how did you know if that implant was a good implant before you started?
From the CT scan, from the CT scan, X-rays, shows.
Just shows.
Oh, yeah.
Because you can see healthy bone around the threads of the
Yes,
implant.
all over.
Yeah.
Build up correctly, all inside the bone.
Okay. Okay. With that, now I'm going to jump to the you got the implants placed. How do you know you've successfully placed all 6 implants? How do you know it's time to go, okay, now we can move to the abutment healing cap piece of it, or basically you got all the implants placed. How do you know that it was a success? How do you know? So is it technology? Do you take CTs?
At the surgery time or later, you mean?
Surgery. So now once you finish placing, you're on that 6th implant. You look at the teeth, you look at the bone and the implants. How do you know it was a success?
While you're placing the implant, you need to feel this kind of anchoring of the implants going on. To feel the resistance. If it's just like going very soft, that doesn't look right. Plus the motor itself we use, it goes with the insertion torque about 45 to 50 Newton centimeter. So if it just keep going, it means that there is no resistance in the bone. If during the insertion the motor at the 45 Newton centimeter didn't go all the way in, means that the bone is resisting more than this force, right? When I get this one, then we stop, and maybe like during the surgery I have to continue by hand, which is more. That gives me confidence, okay, this one is above the 45 Newton centimeter or so, I know. If it just went all the way in, maybe yes, maybe no. So this, I have to count on different device, which we call it Ostel or Penguin, that we put small screw inside the implant and we measure it with kind of frequency thing to give a certain number. If below this number, means that no, it's not really stable enough.
Okay.
This device called Ostel or something.
Okay.
Yes, Ostel, and several brands are out there, Ostel, Penguin, some of those.
Okay.
But if also this one doesn't give me the number I need, so this one I excluded from the immediate loading after the surgery. It doesn't mean it failed. It's just not ready for an immediate loading then.
Okay. So easy way to explain it for our viewers, you want that screw inside of a stud versus in drywall. If you put a screw into drywall, if you're hanging something and you drill into drywall, it spins easy, versus you drill into wood, it's tighter and you know you can hang a lot more weight on it. Easy way to say that?
Kind of.
Okay. So
But sometimes, by the way, also when you mentioned the drywall and wood, but you didn't mention marble.
Oh, that's right.
I'm serious.
Yeah.
Because sometimes we have kind of bone is categorized on type 1, type 2, type whatever, right? Sometimes you have a very dense bone to the extent that it's very hard and kind of brittle, I would say. Doesn't have enough cancellous bone. I mean,
elasticity.
Blood,
so they're a little
blood
bit
supply inside.
Okay.
Kind of. It's just like piece of bone. This is, although it's very hard bone, it's not healthy. It's not good bone to deal with. During the drilling, it gets so hot. Implants also, as much as it's need bone, but too much bone to the extent to be very hard, it will not nourish the osseointegration process here.
Okay.
So sometimes even when we select where to go, in some of the cases that we have to go with the right area of the bone. If it's too dense, this is not good neither.
Wow. Okay. That's something. I've heard you talk about that in the past, that you've had some patients that are just like rock. I mean, it's just really hard to.
Rock is not bad, but again, if it's like kind of marble, only cortical, like no blood supply inside, this is not good neither. So you can drill and you don't see blood inside the bone, like giving you some blood, this is not right. Blood is what you really need for the implant to start doing the osseointegration process.
What I would love to do in the surgery part of this is also ask you, we've discussed this before. I've met with a lot of patients on testimonies. I've met with doctors, but I haven't met with the amount of patients you have. You hear questions and things that you've had to answer from patients that maybe I haven't thought of. Is there anything on the surgery side specifically to this, or any part of the surgery that patients might have asked you questions that you think now would be a good time to bring up?
Why we don't deliver, for example, the same day? Why we deliver the second day?
Okay, which do you feel that was answered when Dr. Ratana talked about now he's got one more data piece for them to go?
No, because some doctors still can do it on the same day, but it's just a denture. We have create some holes in it, and then we have some acrylic to attach it to it, and then go from there. It's good, it's workable, but it's not as accurate as we do it, this impression, and we design it again digitally, and we mill it overnight, and then we finish it. The accuracy is just different. Well cooked versus microwave, kind of.
Okay. So
I have a patient.
Okay.
If you don't
Perfect.
mind, just give me a minute.
Yeah. Go ahead.
Yeah.
Go ahead. So as we get to the point to where you're finishing up your part of the surgery here, to where you've done all the surgical piece of it that we've discussed, you're now putting on the abutments, which are the connectors to the post and the prosthesis. Once those abutments are on, your team puts healing caps on so that Dr. Ratana can come in, sew around it, and keep those abutments in integrity. Correct? Is that a good way to say it?
So many ways to do this one, but in this case, yes.
Okay. Okay. You've done that piece of it. You're now going to hand it off to Ratana, which we've already talked to Dr. Ratana about that. Share with me that when you're in your consultations, or maybe even patients after the surgery or before the surgery, share with me some questions they might have about this process, this day that happens for them from beginning to end. Anesthesia, the surgical piece.
The most famous question, and they want just to assure him this one: I will be feeling pain or no?
Yeah.
Anything else you can do, but do I feel pain?
Right.
So I said, no pain.
Yeah.
But let's put this on agreement again. There is nothing in dentistry called painless. And if he says painless, this is not true. We have some discomfort happens, slight pain might be, but painless doesn't really exist in the dental world. Just face it.
Yeah.
This is the nature of the beast here.
Yeah.
And sometimes the pain doesn't really come the second day or even the third day. Start after that. So the first 48 hours, the patient's still under the influence of a lot of medication and drugs that they start not really feeling the pain yet.
Okay.
But once the inflammation starts, usually by day 3, this when the patient start to feel more pain or more discomfort, I would say.
Yeah.
And they get worried. I was fine the first day or second day, but what happens now? That's what happens. Usually the pain really starts the third day.
Yeah.
And stays out there and has to be controlled with the pain medication, of course. Like it's much easier to control the pain than manage the pain. So be ahead of it. From the day 3 to day 7 or 8, these are usually the least pleasant time.
Yeah.
To be honest.
Okay. So pain, that's always the number one thing they want to know about first and foremost.
Oh yeah.
Okay. What do they want to know about after that? What would you say is a good common question that patients want to know about the surgery, about the prosthetic, about
what I can eat, when I can eat, what kind of food I can eat. Can I go to my physical activities after how long? Normal question that we have to get. Any clinician doing this one need to give the post-operative instructions right after the surgery, which is very common questions. Yeah. Nothing I can think weird out of the norm.
Yeah. What are some things, if you had a moment to address the patient out there, that you would like to encourage them about surgery or about this process to help them be a better patient, to enjoy this process more, to communicate with the doctor anymore? I know it's really vague, but I want to give you a minute as the doctor speaking to the patient that is looking to go through the All-On-X process, 4, 6, or 8, however many it is, but you as a doctor speak to that patient about something that either I've forgotten to touch on or you feel is highly important in this procedure.
That this is not mechanics, okay? This is biology. This is human body. We are dealing with human body, and we do the best we can do, right? We, of course, we study the case, we see the bone, we do this, we do that. Being in this field for a long time, failures or hiccups can happen. Don't go and judge your doctor because it's failed, this doctor is bad. No. We do our best, we do what we can do. Sometimes, for some reason, implant doesn't take well, this or that. You can judge the doctor if he starts to, you know what, it is what it is. No. This is when you can really, but okay, we will work on it, we try to fix it. That's how it goes. We are trying to fix something, we do our best, maybe the patient did his best, but the body didn't react as it should be. Not well. So we need to go and treat that or fix that. Some hiccups can happen. It's not mathematic, 1 + 1 = 2. Not always.
Because it's biology, you're saying that things can happen, and the test of a good doctor is how do they handle that once something has happened.
Exactly. How to handle complications.
Okay.
How to manage the complications.
Yeah.
How to deal with it. How to get the patient under another transition period of treatment to fix that.
Yeah. Well, okay, let's talk about that. There's a multitude of factors why I decided to have my surgery done here. There's a multitude. One of those being you standing behind your work, that if something doesn't go well, you'll fix it. Yes. I mean, simply because the All-On-X is different. It's not like a dentist that had a filling fail. I mean, this is end of the road, right? This is the last stop for getting your teeth done. You're now removing any of your natural teeth. You're setting a structure up to where now you can have a smile, but there's no, it's not like you go from filling to then root canal to then implant to then, you know what I mean? Like there's not a progression. This is the end. And so was really important for me having a lot of dentists in the past that didn't stand behind their work, and they would say, it's crazy, it's like a flashback. Just is what it is. You know, wait a second, whoa, hold on, what's the solution here? How are we gonna make this right?
Yes, and true that the implant success rate is about 97, 98%, let's say, but there are 2% out there that something can go wrong, right? But the point is why they go wrong and what happened. This what we need as implantologists need to evaluate and see and start working on it, right? Patient need to understand that this is biology, this is human part, and we are replacing a missing part and rebuilding something inside the bone, right? Body reaction differ from one to another. So in case hiccup happened here or there or something, the patient need to be understanding that this is not the end of the world here. Things can happen, can be managed, can be fixed, can be repaired, might need some time. So just be patient. Sometimes, yes, the failure happens because of wrong decision from the doctor or from the patient or both together, regardless. But we need to fix that, right? What we have done wrong before, we need to do to make it right. If the patient didn't really comply, let's this time change the way a little bit. If something went wrong during the surgery the first time, let's do it next time. Different. This is how things can go. Of course, like if the doctor told you it is what it is, live with it. No.
Yeah.
Doesn't work this way.
Right.
But if the doctor is willing to be with you, next to you, help and try to fix the problem. If he said, okay, I will fix it, give him the chance. He said, like, this is now out of my scope. I would refer you to somebody can do it for you. Fine. This is a trust.
Mm-hmm. What do you do if you're a patient in that situation, though? If all of a sudden something fails and a doctor says, I'll refer you out to someone else who will fix it, do I have to pay that someone else to fix it? Or does that doctor, how does that work?
This will go a very big
Sorry.
area here. Sometimes we get refund, sometimes whatever. I mean, it's just...
Okay. Well, I mean, I'm a patient.
Very big area.
I know, and I'm a patient, and I'm always going to advocate. It's just I've been in that position before, and it's like, wait a second, I just spent $3,000 with you, and now you're referring me out to fix something that didn't. But again, this being the end of the road with what you guys are doing, it really as a patient. Who now, it's been over a year. It's been over a year since I've had the surgery, since this happened. I mean, the first set of temps you guys put me in, I mean, I've seen some temps. Those were good. Those were very, very nice temps. Temporary prosthesis. When I'm talking about temps, I'm talking about the teeth that they gave for me to wear during the healing osseointegration stage. I want to pause for a second because you brought up something that I wanted to come back to, immediate loading, and sometimes you don't immediately load. Mm-hmm. Immediately loading means you actually screw an abutment and the prosthesis into the implant that was just placed. And that doesn't usually happen on single crowns. He's talking about if he placed sometimes a prosthesis and you place 6 implants, sometimes you might only load 4 during the healing stage.
Sometimes nothing.
Sometimes nothing.
Sometimes nothing. Sometimes okay. And I always tell the patient, even before the surgery, when I see the condition of the jaw, maybe you are not one of those, but sometimes it happens. Bone is not that great. We need to put the implant and graft, and the implant definitely are not in a very sturdy position or strong position to have an immediate loading, which is this bridge that we install the second day. Sometimes, I can see it obvious from the beginning. I'm telling you, we are removing the teeth, placing the implant, and we give you a denture. Yes, this bad one that everybody hates for about 4 months or so until the implant heals. Or I would tell them, I have 50-50 chance for that can happen. If I don't feel the implant are good, strong enough inside the bone while insertion, I might have to give you a denture. Or if it helped me out, I will give you the bridge. You just need to be upfront with the patient about this particular piece before the surgery. Yeah. The patient really doesn't want to wake up from the IV sedation and tell, hey, you have a denture. No.
Right.
From the beginning, from the consultation time, there is a chance that might happen.
Yeah.
So we don't want to discuss this while you're in the chair at the surgery. I'm telling you from now, it might happen.
How many times, and I know, I mean, the next day after our surgery, I remembered as I was watching it again last night, preparing for today, that was fun. But you had a double the next day. You had 2 upper and lowers the next day. So 4 arches.
That's, but relatively simple. You can't really do 4 arches in one day unless they are relatively simple.
I mean, that's pretty intense.
It is, yeah.
And so, but in that process, when you have the ability, you've done a lot of these, how many of those end up being, they go home in a denture? And I think this is good. It's real. It's not salesy. I mean, this
And
is
by the
something.
way, sometimes the upper is denture. We do upper and lower, right?
Yeah.
Sometimes the upper is just denture, the lower is fixed, right?
Okay.
It just the lower jaw was in a better condition bone-wise than the upper, so patient can go second day with upper denture and lower fixed bridge, right?
Yeah.
It's again, it happens every now and then. I would say 5% maybe can happen this way, 10% can happen this way. You just can't really tell exactly how many. It depends. Like, it's case by case thing.
I know that sometimes even some of the other high level clinicians like yourself that we've interviewed for this, there's always a level of frustration and something they want to tell their other fellow clinicians that might try to cut corners or might not try to do it right. If you had another clinician watching this or a group of clinicians, what would you like to say to them?
Knowledge never ends. So how many times I changed my techniques and developed it? I will not be exaggerating if I tell you every single surgery. Every surgery you do, you know more, you learn more. Matter of fact, sometimes my frustrations comes the more I learn and read and watch. I feel so way behind. I still there's a lot to do. So never think that you got it all. It will never get it all. You always keep improving skills and techniques and extraction and suturing and loading. It just never stops. Never stops. I don't say like after 10 I will be confident. After 100 I'll be confident. No. The more you do, by the way, the more that you know that is still a lot to learn.
When, in your opinion, so this is just opinion, in your opinion, when would a clinician be ready to start doing these type of procedures?
No, this is a long story here. No, again, this is full mouth reconstruction. Before you go with the full mouth implant placement, you need first to learn how to place one implant, and graft it, one implant grafted with immediate loading, a couple of implants together at the same time, multiple extraction. It doesn't go like I'm going to do All-On-4. It doesn't work this way.
Exactly.
No.
Exactly. No. So you just keep walking us through it. So now they have to do multiple implants with some grafting. What would the process look like? Where do they get to? So they've already done everything that you said, and they've done some of them. Keep going.
Okay. Single, multiples, full mouth reconstruction. I mean, start planning to know. I mean, it's steps.
Yeah.
When I said like we remove all the teeth and we place implants, right?
Yeah.
Imagine that each one of those is a case here. This tooth number, whatever, it's pulled and placed and grafted. Imagine that you need now, within a couple of hours here, to do 5-6 procedures together.
Right.
And connected.
Right.
Because at the end you have one prosthesis going in, planned. So this kind of like training, we give it in courses, like long courses.
Yeah.
Extensive. It's not that simple.
Yeah. I guess coming at it, what I'm trying to do.
I have been there, single implant first, then couple. I mean, like I didn't go do this all of a sudden. No, it takes steps.
Right. Right. And I guess that's part of what I'm hoping to convey to some of these doctors out there. Because I know from a business standpoint why it looks attractive. I do. I understand why it looks attractive. From a patient and a clinical standpoint, it's very complex. It is.
But it's doable. Okay, it's very doable. Just don't go to the next level without finishing level 1. Finish level 1, go level 2. Finish level 2, go level 3. But don't jump from level 1 to level 5 and say like, I'm gonna do it. It doesn't work this way. No.
Okay.
This is higher levels. Before we get there, we have to pass through the first few levels and master it well and do it right, and then go to the next level.
Okay. Well, again, want to go on record and thank you for everything you've done for our family. It has been a great relationship, and I didn't, for the record, was not working alongside you in a business relationship when we had this done, that we had served our time, that you had grown to the level that you had grown to, and we were no longer doing business together. This was a choice to come with, and we had options out there, but I'm really glad we chose, and I specifically chose to go here. And the fact that none of this was paid for by you, none of this was paid for, meaning what we're doing today. I mean, that's a big deal. I want patients to know that I paid. We negotiated a price. I'm paying that price. I didn't get a discount for doing this. You didn't even know I was going to do this when we first discussed about this procedure.
Still till this point, I don't know what you are doing, to be honest with you.
Well, once you see it, and that's the way I've kind of wanted to keep it. So the fact, once you see it, I think it'll be good. And I know you've got to go see a patient. Okay, you know what? I'm going to let you go. Thank you, Dr. Iskander. Seriously, thank you.
Okay, thanks.
Appreciate it. Okay, that's going to wrap today's session up. Unique, trying to get this filmed in a dental practice that's rocking and rolling and getting these doctors time. But I really wanted to try to make it a point to get this on record so you guys can understand what I went through, what the reality, blood, guts, and gore. There's times I'm waking up and it hurt at times, but wait a second, if you guys know what you're getting into before you get into it, you're A, better prepared, and B, you're able to have less fear. Dental anxiety is real. And I really want to speak to those out there that get freaked out at it. I am that guy. I'm talking to myself about that. I understand how freaked out and anxious you can get at something like this. And if you've taken the time to walk all the way through this video and spend with us asking questions while we looked at some stuff that's less than pleasant, trust me, I mean, I had to watch this last night in preparing for this, and this is the first time I've watched it since the surgery. I don't want to watch it. It makes me, my hands get a little sweaty and I get a little nervous. And I mean, you ask my wife, even last night, I'm like, whew, that kind of got me a little edgy on watching it. So I understand the fears that can come with this. I want to encourage you that if you do the homework, you listen to the experts, you take time up front. They talk about the case planning. The case planning starts with who you choose. So making sure you ask some of these questions. I hope that this has really helped you guys in some of it, even though some of it's been graphic. I'm sitting here a year afterwards saying, even as an anxious patient, it was highly worth it. So I appreciate you guys joining us for this. Again, if you have not followed us, first time viewing us, well, congratulations, you're brave for starting off with a video like this for your first time getting to know the Smile Mentor. But please follow us, subscribe to us. We will have a lot of good continuing content coming out. And for those that don't even know what the Smile Mentor is about, you should kind of know something at this point, but there's a video about the Smile Mentor down in the description below. So we really appreciate you guys, and yeah, here's to smiling big.